We're down to the final leg. We have Dr. Elizabeth Bryce up next. Dr. Elizabeth Bryce is the Regional Medical Director for Infection Control at Vancouver Coastal Health Authority and has been involved in the field of infection prevention and control for the last 20 years. She's duly qualified medical microbiology and internal medicine and is a clinical professor at the University of British Columbia. She's the past co-chair for the Canadian Nosocomial Infection Surveillance Program and the current co-chair for the Provincial Infection Control Network of British Columbia. Dr. Bryce is one of the founding members of UBC's Certificate in Infection Control, as well as several online education modules in this topic. She's a long-standing interest in the field of cleaning, disinfection, sterilization, and has published several articles in this field. In keeping with the struggles of cleaning and disinfection, Dr. Bryce has opened Pandora's box of challenging organisms. Please welcome Dr. Bryce.
Thank you. I'm very delighted to be back here. Actually, I did medical school, so I've got roots like Jim does, and I haven't been back for 10 years, so it's nice. I hope the weather improves, but we'll see how it goes. How is everybody doing? Is everybody starting to flag a little bit? I applaud you for your stamina. I'll offer you a bit of an enticement. I'm going to try to be finished within 45 minutes rather than an hour because I realize that it's been a long and very edifying day. And sometimes we start to suffer from a little bit of information overload. So Nicole's going to give me a heads up around 20 minutes and I'll try and adjust myself accordingly. So, when I was asked to present, I wasn't just given a Pandora's box of organism, I was given a potpourri of subjects. And after a mental eek, I thought, okay, I think we can pull this together. And then after listening to the many learned speakers here today, I wrote a few notes and a few quotes from some folks, and I'm going to try and streamline my talk to address areas that have already been addressed, and then maybe do a bit of a point-counterpoint on some subjects. So in essence, what we hope to do by the end of 45 minutes rather than an hour is Dr. Sitar very ably talked about some resistance mechanisms, but I'm going to take you more down to the molecular level for organisms as to why they actually work the way they do. And then, again, we've had a good overview of cleaning. I'm just going to use cleaning as a bit of a segue into a topic called human factors engineering, which I think some of you are already familiar with or will soon be familiar with. And then I'm going to try and complement what Mark did with cleaning disinfection programs and looking at some of the science, more or less, quasi-science, where it is now. And maybe, where's Mark? I can't see his face right now. I might do a little point-counterpoint with him. And I'm going to restrict this to surface cleaning because all of these are lectures in themselves. So, you've already heard this. You know that resistance to disinfectants really depends upon the organism, and we're going to talk a little bit about the cell wall structure and composition and physiology for those geeks in the audience here as to what makes some organisms more resistant than others. And then the next two bullets, I think, Michelle, you're going to cover some of this under biofilms, and that is under the broad heading of really contact with surfaces. And then I'm going to talk about disinfectants, not really the agents themselves, really how they're used. And that's human factors and human factors engineering. So that's the agenda for the next 45 minutes. So the first thing, this is a much more simplistic diagram than Dr. Sitar's, but I am kind of a lumper rather than a splitter. And I thought that just to give you an overview and show you how I'm going to work backwards, I'm going to start with the target and then work all the way back and then not focus on the agent but focus on the process under the term human factors. But in essence, the point being that for something to be effective, it has to be the correct agent, in the correct concentration, for the correct amount of time, with the correct application method. It actually has to come in contact with the organism, it has to penetrate it, and then it has to reach its target still in sufficient concentrations to have an effect. So, with those basic principles in mind, we are going to talk about, actually more than four, we're going to talk about 5 organisms because although Nicole suggested spores, prions, viruses, and parasites, I thought, TB is probably a little bit more common for us in the healthcare business than prions. So that's the agenda. So I'm going to leap right into spore-forming organisms, and I know there's some microbiologists in the crowd, and I'm a generalist in everything and an expert in nothing, so I'd be really pleased for their input if they have any comments that they want to make. But I wanted to get down to what is there about a spore that makes it more resistant? And it's really, I guess, to a microbiologist, kind of an exciting topic. And I know we have no lives, but to me, it's a complex process. There's actually 7 stages. Trust me, we're not going to go into those stages. We're just going to talk about the general concepts. What you have is you have a vegetative cell, the mother cell, and instead of dividing normally, when it happens to undergo some sort of environmental stress, it puts all its machinery into a process that's called dormancy, where it's going to shift its metabolic functions so they're just at a minimal level, and it's going to go into the production of a spore, whose sole existence is to protect its nucleic acid. So what happens first is rather than dividing by binary fission, it starts to divide asymmetrically, and then it starts to condense. The nucleic acid goes into a spore coat, and the mother cell starts to dehydrate. And till finally the end result is the release of a free endospore. Now, when I'm talking about endospores here, I'm talking about gram-positive organisms. I'll make a distinction. I'm talking about bacteria rather than fungal spores, which are more there for reproductive purposes. And the ones that you know already, Clostridium difficile, Bacillus. And if some of you have never seen a picture, that's what a spore looks like. It doesn't take up the dye very well, so you see a hole in the cell. So, a little bit more about the structure of the spore. So what happens is you have got an object that has 30% of the normal water content of a vegetative cell. There's a reason for that. If you have water is a good conductor of heat, it's a good conductor of chemicals or other substances that might be adverse for this organism's existence. If you can condense the amount of water you have less ability to conduct heat and less ability to conduct chemicals across to the core, where the nucleic acids live. And the nucleic acids live with some proteins. Most of these are called small acid-soluble proteins, and they're there to provide the basic substances for living when this organism regenerates. So it's nicely packaged in the core. There's also other amino acids and calcium, and their job is to bind to the nucleic acid, again, to superstabilize it and to protect it from heat and chemicals. So really a sophisticated design. You have the outer membranes and the germ cell walls. They have peptidoglycan like you see with gram-positive organisms, but different cross-linking structures. So there you have it, a really nice package, very well designed for survival. With me so far? Okay. I thought I'd go to mycobacteria next. There, you can quibble. Prions might be just below spore formers on the resistance scale, or you might see them as higher. But what I wanted to do by having one after the other is to show you the difference in the cell wall. Now I thought I could make my cursor work. Can you see the cursor? Yeah, you can, good. So I wanted to show you the difference in the cell wall between this and a traditional gram-positive organism. So here's this peptidoglycan that some of you have made or may have heard of contributing to the cell wall structure. But this is actually a 3-layer cell wall with, I keep losing my cursor. Here we go, arabinogalactan and mycolic acid contributing to a very thick wall, which gives a very good permeability barrier. Furthermore, the mycolic acid it's described as waxy, and that actually, for reasons that I don't really understand, have a very specific ability to inhibit the activity of quats. So if Michelle or Dr. Satarif or Syed, if you know the reason for that, I'd be glad to have myself educated here. Prions, rare, about 1 in every million cases, and it has a spontaneous mutation for prion disease. Prions are normal proteins that we have in our body that are linked to cell membrane function. And a series of events happens, not clearly understood, where you get the development of an abnormal protein. And this abnormal protein has a different conformational structure, and it prevents degradation by proteases. The same, and then that accumulates as amyloid plaques in your brain, and then you have diseases like Scrapie and CJD. The same thing, the same conformational change that contributes to resistance to degradation is why it makes it more resistant to the disinfection sterilization process. And really, when we try to target killing, if you can call it killing, because, I mean, really it's a protein with no nucleic acid, but disruption of that protein, what you aim for is to fragment the protein, and that's what things like sodium hydroxide do. And the converse of that is in the histology lab, there are some chemicals that can be used that will actually fix and stabilize the protein. So for example, when we fix the brain in histology or a piece of tissue that we suspect has CJD, we don't use formaldehyde, we use formic acid instead. So, there has to be some thought processes in what you do when you're addressing resistant organisms like this. Sorry, I'm saying organisms, but it's not really an organism. Now, Dr. Sitar, you covered enveloped viruses very nicely, and you talked about how well it can resist the disinfection process when it's in food particles. And the same thing happens with cell debris, protein, biofilms, which I'll leave to Michelle. But I bet you not many people know that viruses have the ability to aggregate and clump. And non-enveloped viruses are very good at this. It's kind of like the circling of the canal or the herd effect, the circling of the wagons or the herd effect. So viruses will aggregate to protect an inner core of viruses to confer a survival advantage. And non-enveloped viruses are pretty good for that. The classic example is polio, which could be resistant even in swimming pools with chlorinated water. And norovirus has that same ability. So they've got some pretty neat protective mechanisms. And the last are parasites. Now, let's face it, we don't have a lot of parasite encounters in infection prevention and control. The exception probably is Cryptosporidium, and really I can't even think of when we've had a Cryptosporidium outbreak in a facility. If any of you've had, please let me know. That's more seen in things like foodborne outbreaks, for example. And really the two most resistant parasites are Ascaris and Cryptosporidium. And it's really due to the thickness of their cysts or their eggs. The practical application for Cryptosporidium is it's relatively chlorine resistant. So in some water treatment facilities that rely on chlorination rather than chlorination and filtration, because filtration is the way that a lot of water treatment plants get, decrease the load of Cryptosporidium. Sometimes if you're in communities that don't have filtration as a mechanism, you'll see boil water advisories for immunocompromised people, particularly when turbidity levels rise. So that's the practical application, again, of what you see for a parasite whose oocyst is rather or relatively chlorine resistant. So, first whirlwind. Are you with me so far? You still there? Okay, I put in a diagram. It's purely for reference purposes. I just wanted you to have a good reference for the action of different disinfectants and then the resistant mechanisms, some of which are inherent, like aggregation for viruses, and some of which are external, such as biofilm. And I put in a table with all the different disinfectants, the traditional ones, I must admit. And I put that in there so you can look at the mechanism of action, and so you can see that denaturing protein is a big mechanism of action of disinfectants. So that's all I'm going to do for that. Okay. So we've talked about the organism. We've talked about the different targets and mechanisms of resistance for selected organisms or proteins, as the case may be. And I just wanted to touch very briefly on surfaces because I know a lot of folks have done that. And let me see, what was the quote from you, Dr. Sator? It was, "The surface itself has a demand and a life of its own." Do you recognize your words there? And I couldn't agree more. You heard a life of its own from things such as copper and electrolyzed surfaces, but a demand of its own would be integrity of the surface. So anything that's got seams and cracks and porosity, any factors that affect cleanability will affect the encounter of the disinfectant with the organism. And you've heard about resistance to microbial growth, good or bad, Jim. So bad with triclosan, intriguing, but we don't know the full impact with copper, for example. I did put in one study for you at the bottom, which is probably the biggest crossover study done with copper for those folks who are interested in looking at that and making some informed decisions on your own. So, and we also heard something about cleaning. And my purpose here is not to go over that same thing, but to totally concur with Dr. Satar about the physical and the chemical process and how we really don't evaluate the physical process as well as we should. And that's going to be my segue into human factors, which really looks, or can look if you let yourself go that route, at the whole process of cleaning. And the need to take into account good old elbow grease and physical removal of the agent. I threw in a slide, and I debated whether I would put this slide in because I think the audience could think we were maybe foolhardy in our original approach. But when we became regionalized, we started doing surveillance with other facilities, and we had one facility that had a great environmental challenge. It had hardly any washrooms in the patient rooms, almost all of which were multi-bedded rooms, and 6 to 8 and sometimes 8 to 10 patients sharing a washroom in the hallway. And this, before the days of PCR, the rates, as you can agree, were quite high at the point that we started doing the surveillance. So, brave or foolhardy souls that we were, we decided that we would not use a sporicidal agent, that we would look and see, could we have a less impact on the environment and just pay meticulous attention to cleaning, and what impact would we have? So you can see we had a dramatic reduction in rates first off, then we had a norovirus outbreak, and then we continued to fall, except for little norovirus outbreaks when with more diarrhea, more possibility of transmission. And even when PCR was initiated, actually probably about here for that hospital, which increased our sensitivity of detection by 30%, we were still able to just trot along with our usual AHP, nothing else, no change, meticulous detail, until now, as you can see, that one very environmentally challenged hospital is down to below provincial levels. Now, the caveats with this, of course, Jim, we had antimicrobial stewardship, and of course we paid attention to hand hygiene. So don't get the impression that all of this is just a single factor. But I just use it as admittedly anecdotal to emphasize the importance of cleaning. So now we're at the agent. And as I said, I'm not really going to talk about the agent per se. I'm going to talk about the process of cleaning. And that comes to the role of human factors. Now, just to stop for a minute, how many of you folks in your institution have human factors engineer? Can I see a show of hands who's got one? Nobody, yeah, so we've got, yeah, Linda, put your hand up, we've got one. So 4 people in the room have human factors engineer. How many of you folks have heard of human factors engineering? Okay, that's good. So quite a few more. All right. So there is the formal definition. I'm not going to read it out for you. The history behind human factors engineering actually comes from the computer world, when a person called Nielsen looked at the interaction of people with computers, and he developed a list of heuristic principles to facilitate better interaction between humans and machines, in this case, computers. And then it next moved to the aviation industry, other manufacturing industries. A lot of it was wrapped up in ergonomics, but the science has evolved tremendously in the last 10 years. And even within human factors engineering, there's subspecialties. So you'll have a cognitive engineer, you'll have an ergonomics engineer, you'll have a usability engineer, and now you're having a human factors engineer that are specifically trained or have taken I guess it would be like a subspecialty or a focus on hospitals and how the hospital environment interacts with human beings. And I think lately I was just reading Wikipedia, like Jim, I have such well-resourced sources of information sometimes. And the military has decided that this is something that they want to look into, whether you think that's a good idea or not. Now, what is it? I think I've said it, but just to re-emphasize, it's really looking not at how we err. That's not what this is all about. It's a totally analytical, non-punitive way of looking at the world in which we interact with either an environment, a machine, a piece of technology, or even a process like isolation. You know, how do we interact with the isolation process? And what a human factors engineer tries to do is they try to look at all the relationships that occur in that encounter, and they look to optimize it. So rather than building a system and then seeing how we use it, ideally, as the system is being built, humans are interacting with it and people are observing their interactions. How many of you have been involved in purchasing decisions when you're looking at cath locks or IV catheters, or you're looking at, I'm having a mental moment here, intravenous and touch the keypads, and even look at keypads on your phones, on your computers, and on IVACs. Sorry, there's the word, I knew it would come to me. And you'll see that they can be configured quite differently, with the numbers in different positions, the on and off buttons in different positions. So that's kind of an example of what a human factors engineer would try to do. They would try to minimize errors that we can do as humans by making the system fit us. They do it through a number of approaches. I've given you some examples here. And we're going to get into them more, so I'm not going to belabor that more at this point. The only thing that I'll highlight here, because I know I'm talking about the other items, is not just looking at the environment, the equipment, the task, and the training, but they also select or profile individuals for the job. So the classic example I can give you, and one that we tried to put into our facility, is that you have cleaners, right? But not all cleaners, or environmental services folk, are suited to specific tasks or environment. So the environmental services person that works in ICU might have a different profile that better suits them to that job, same with an OR worker, than somebody who would work on a floor. So as part even of the selection and hiring and appointment of workers to different work environments, there's a whole science that looks at the individual and where they should work, even though they're all doing what is perceived to be the same task. So I had our human factors engineer, Allison, look at this to tell me if it was actually how she would look at things from her perspective. And she did tell me that, yes, it was pretty well what she would do. So I heaved a big sigh of relief. And I've done this on kind of a big scale, the big scale of cleaning. But you could actually break components of this down and look at one thing. So you might, for example, look at the cleaning cart. How is the cleaning cart designed to facilitate ease of use for the individual, prevention of cross-transmission, and to make it as intuitive to do your process or the task that you want? So you can go from large scale right down to the micro level when you're looking at human factors. So I'm going to break it apart. Some things your human factors engineer will rely on your and environmental services knowledge. They will take it as a given, for example, that you know the efficacy of the product that you want to use, that you've researched whether it's inactivated in the presence of protein, does it have a long shelf life, does it interact with other materials, etc. So that's where you will often come into a role with a human factors engineer, because they will rely on you for that information. But they might look at the packaging, for example, to see, does it look familiar? Is it easily identifiable as to what that chemical is for? And can it be distinguished from other chemicals? So you've seen this on medications. They've all hit the press where you can mix morphine and morphine derivatives up, and the one that hit the press was the heparin in the infant from the, I can't remember who the movie star was, but so you see living examples. But the same things happen with disinfectants. You'll see concentrations in really small print, so it's hard for a user to identify it, or packaging that looks very similar. We see it in our wipes, for example. And what human factors are trying to do is they're trying to build enforced functions so it doesn't rely on our cognitive ability or our memory recall, so that you can readily identifying without having to say, oh yeah, I remember. It's this one with this little tiny green bar. That means that it's 0.5% versus 5%, for example. User-friendly. I had a good talk with Allison before I left, and she was very adamant as an engineer that they prefer things that are ready to use. That if you have to rely on concentrates, you're relying on yet another step in the process, and again, you're relying on people's memories and ability to do the task right. And I'm sure there's probably a few of you in the audience who have actually measured the chemical content of disinfectants when they've been prepared by staff, and I know we have, and actually have been quite surprised at the variation in concentrations that have been made up despite the best efforts of staff. There are devices that manufacturers make to assist with dilutions, but no system is perfect, and the more steps you have in a system, the more complicated you're making a task. They also look at, is it easy to pour or remove from the containers? And is it easily stored, unbreakable, ergonomically good? They even looked at the handles of our disinfectants, and did they fit and did they conform to use for the individual? Safety, again, they rely mainly on your expertise, so I won't go into that. Now, I want to spend some time on the individual. There is a whole science, and human factors engineers spend a lot of time in their studies studying human psychology, cultural values, attitudes, knowledge, beliefs, and how this comes into play when they do a task. And I guess the key points that I would like you to take home is that consider the educational background and the cultural background of the individuals doing whatever task it is that they're doing, that you have got an eye on. So often we say, well, we'll make it English level grade 8 or something like that, or we'll put it into plain language, all of which are very desirable goals. But in some professions where English is a second language, you also have to take into account not just the current English level that they have, but the education that they had in their previous country and the cultural beliefs that they've had. I've seen examples of you're doing process audits and you're watching somebody do a task and they'll do it quite differently because they believe it's the better way. It's not to say that it necessarily isn't the better way. I'm going to talk about positive deviance as it pertains to this in a moment, but you really have to consider this. And that all plays into training. One of the things I was very pleased to hear this morning from Mr. Heller was the need that everybody understand what the key principles are and what the expectations are. I would also say that people have to understand the big picture. Why are they doing what they're doing in that way to give meaning to them? And we often forget that in training. And we're hampered in infection control because we have a number of cognitive barriers, a human factors engineer would say, that make it difficult to get people to comply. We have delayed feedback. You know, Mark talked about the importance of audits, but even for a nurse, for example, you don't see the immediacy of what you do is causing an infection, right? And so we lose that. The next thing in human factors they look at is the connection to what you do and the event, that being the infection. And for many people, it's remote, right? And we don't have a lot of infection control cues that are right there at the time of the task to remind people. We've got things, tools such as GlowGerm, but we really have very few infection control cues. That plays into training. It's no good just to have somebody read the manual and then do the task. And furthermore, it's not good enough to train the trainer unless you have evaluated the trainer to see if their training meets the expectations of the organization. And that comes into competency evaluations of environmental services workers. It's no good just to do competency evaluations of the frontline workers. Periodically, middle management should have competency evaluations as well, just to make sure that everybody is on the same page. The last thing I think is making things illustrative or pictorial wherever possible. So the process, I think you know all of this. You should have swift execution times. You heard from Dick about the importance of that. The fewer steps possible, and reduce mental workload and ability to have to recall things. So something that I could think of was color-coded buckets and cloths to make it intuitive, and to encourage people to do the right thing in the right way at the right time. I think I've talked about most of this. I think I'd just like to emphasize optimal application tools. It's no good just to give somebody the agent. You need to give them the right tools for the job. So it may be tools that with our infection prevention hat on, we're thinking, oh, we gotta have good tools that really clean. But they also have to be ergonomic, right? And they have to be something that the worker wants to use and is motivated to use. I want to bring in positive deviance here. I mentioned that personal belief should be respected, and positive deviance is one of the tools that human factors engineer use, and that's looking for the people who deviate from the process but do it so that they have a positive outcome. And anything that a human factors engineer does is not a single observation. It's multiple observations over time in order to really analyze all the steps. And they deliberately look for positive deviance in order to learn more about the system and how it might be optimized. And they make very good points. There's an excellent article, I'll see if I can get the reference for you and add it to this, and it's called Human Factors and Infection Control. If anybody has seen it, it's an excellent review article. And the person makes the point that by looking for the positive deviance, what you're doing is you're respecting the individual. You're respecting their opinion. You're rewarding and recognizing ingenuity, and you're making people feel that they're really part of the process and part of the solution. So positive deviance and human factors are really intertwined, as are lean initiatives. So do not think that these are mutually exclusive. It's just a set of tools that people use. Allison gave me this slide, and I was struck by how similar it is to our hierarchy of infection control, or the hierarchy of occupational health. And it just emphasizes that whenever possible, put in forced functions to make it easier for folks. And education, as we all know, is the lowest rung on that tier. Okay. Next subject, assessing surface cleanliness. Now, is Mark here? Am I going to put him on the spot? Oh, he had to fly back. Oh, too bad. Well, this way I get to say anything I like. Oh, rats, and I had a whole selection of little quotes from Mark, but I'm going to put them out here to make sure I remember. We actually had a little bit of a debate and probably bored everybody at the dinner table about this last night. So I hope to be complimentary to what he said. And I think for the most part, I really am. I think he'd be nodding his head here when we recognize the limited resources to implement an assessment program. Very few of us have been given the resources to put in quality assessment programs, whether you have non-contracted or contracted staff. And many of us are now being made to do it off the side of our desks. And that is not a good arrangement to start with. Mark and Dr. Sitar both acknowledge that there's really no standard method for assessing environmental cleanliness, either through process measures or outcome measures, which I'll get to in a minute. And there's a lot of debate about what is the best way to assess surface cleanliness. So, with all that in mind, I thought, well, what am I going to do here? I thought maybe what I'll do is I'll take you through the difference between a process and an outcome measure so you can see why you probably need both of these. And then I picked on CDC. I shouldn't say picked on them. I decided to use them as a template because I think they have done many things that are worthwhile in their document on environmental cleaning assessment. So I used that as a springboard to illustrate some points. So first things first, outcome versus process measures. An outcome measure measures the end result or the byproduct of a task or an action or a process of care. So a classic example would be mortality, right? And in the cleaning world, it might be something like ATP, UV gels, microbiological cultures. By the virtue of how it's collected, it's going to represent all aspects of the process of care or the steps in the process. So it is less sensitive, and it's not really able to tell you what specific actions are going wrong. And because it's less sensitive, you need more observations. You need a sufficient sample size so you can understand, oh, there's Mark, great. So you can interpret your data with caution. Somebody must have come and got the word out, Mark. Now, process measures are the opposite. They capture all the steps in the process. Now, the caveat to that is you've got to have a really good tool, and you've got to vet that tool well, because if you miss steps in the process, it's only as good as what you have designed it to measure. It's way more sensitive to differences in the care process or the task, and so it's easy to interpret, and it can really identify the remedial action that you might need. And so you need a lot less observations. So, if you just came in the room now, Mark, I said that I was going to select CDC as a template, and I guess now I'm not going to have an invisible counterpoint with you. You're actually in the room. So CDC has an excellent document. I put it down below, and it's 2010. I think it was drafted, Candy, was it 2009 that it was drafted? Oh, Candy doesn't know. I thought she knew everything. And it suggests 2 levels of evaluation. Level 1 is for those just starting out. Level 2 is for those programs who have achieved level 1, obviously, or for those who have increased rates of healthcare acquired infections that kind of compel them to a more, shall we say, focused series of actions that have to be taken. The reason I liked the CDC tool is they were quite explicit and very descriptive of the tools that they recommended. Now, and that's not to acknowledge, I have to say, all the other good tools that are out there, because there's some very good things coming out of Ontario and the UK. This is just one illustration. So a level 1 program recommends, again, totally simpatico with Mark here, that it has to be a combined effort with infection control and environmental services. It really has to be collaborative. And I'm glad to see that we are also simpatico that you have to know what your expectations and your checklists and what the ultimate goal is, and it has to be aligned with the organization's expectations. It's no good if it doesn't measure what it's supposed to measure, or it's not aligned with your facility's values. And it clearly, before you've even gone into this process, you have to understand who in the zoo and who's responsible for cleaning things. I bet you if you put an infection control practitioner, environmental services worker, a nurse, and middle management in the room, and you ask them who cleans the commodes, who cleans the blood pressure cup, blah, blah, you would get different answers from everybody. So I liked that the expectation in the CDC document was that just as groundwork, you outline those roles and responsibilities. Now, what they recommend in level 1 is monitoring of staff education, and they use competency evaluation. And as I've already said, I think that my personal opinion is competency evaluation should not just be focused on the frontline worker, but should be focused as well on middle management to make sure that everybody is on the same page. And I was really heartened to see that the CDC document does mention that. Where I disagree with them is they say perhaps combined with patient satisfaction surveys. And I find patient satisfaction surveys are usually thrown in with a whole bunch of other things in the satisfaction survey. The questions aren't well worded. You're not sure what the expectation is. It's highly subjective. And I find it difficult, my personal belief is to reconcile that with using it as a cross-validation for competency evaluations. I understand the importance of getting the feedback from the patients, but I find it hard to accept the rationale that it can be cross-validating. And again, totally agreeing with Mark, it should be a standing agenda item on either your quality control or your infection control committees. Now, level 2, 5 minutes left for 45? Okay. It's the same as level 1. But they add objective assessment of terminal room cleaning. Now, you've heard all about the different methods. You've discussed some of them. They give you some of the options. Not quite in agreement with you, Mark, there. They actually want you to say a score. And they want to make sure that you meet the score and that you do this at least 3 times a year and in a sufficient sample size to detect a change in performance. And they give you a way to calculate the scores. And they give you sample size selection criteria. So approximately 15% if you're greater than 250 beds, if you're less than 50 beds, 15 observations. They go into how to calculate your sample size. And they have a pretty good table about looking at the different methods that you could use, how well researched they were at the time this document was done. You have to understand that this document is 2 or 3 years old already. And you can see that fluorescent gels kind of rose to the top, the DASO systems, for example, that Dr. Sitar was outlining. And I circled direct practice observation because it's really the only process measure that we have here. They give you a tool kit and a checklist. We used that. I have to say we modified it. When you have a regional system and you can generate big numbers in your sample size, we wanted to look at the trends because, again, very consistent with what Mark said today, it's the trends that are important. It's not the one point in time. It's how you're doing over time, no matter what system you're using for monitoring. And we liked to see not just the date, but the time of day that the audit occurred, the unit it was on, the room, and whether the room was single or multi-bedded, and whether the cleaning that we did was isolation, discharge, and we've actually added another one, a routine clean. And we actually have a process of randomization so that people pull the card when they go to make sure that we've truly randomized, because human beings, what we are, we may just decide we're going to select that area because we think there's something wrong. So we tried to put some rigor, and we changed the high-touch surfaces a little bit. One thing I liked, let me just go back, about the CDC document was they looked at high-touch surfaces and they grouped them into 5 categories, very consistent with what we heard earlier today, with a higher weight given to those that are closer to the patient. So they give you a way to do a thoroughness of disinfection cleaning score, and that's really just the % of the objects that were cleaned by whatever method you were using. And the key point here is that you feed back immediately to the staff. And actually, just from the process that we learned, and Linda can probably attest to that, it's important to feed back in 2 ways. One, of course, is to management and senior administration and to your quality committees, and to do that in a way. But the other is to feed it right back to the worker immediately. We developed a script for the people who are doing the audits so they can tell the patients and families why they're there. And we, after doing some piloting, realized that we needed to develop a script when the family asked what their results were. And so our script basically says the room has passed, or there are a few items that weren't cleaned, and the action that will be taken is the supervisor's being contacted immediately and your room will be redone. And then we would feed back to the service worker. And to be fair, it's not always the same service worker on shift. So it's not done in a punitive way at all. It's done in a collaborative learning fashion. We thought you might like to know the results of this room, which they may not have cleaned, right? They just happened to be on that day. And then could you share it with your colleagues? And I have to say that's gone over very well. We've only actually had pushback from one service worker. And importantly, it's done with environmental services. This is not a stand-alone process at all. I think it's an objective means of doing it. I have some problems with self-auditing. That's my personal opinion. I think self-auditing, it's like you said, Mark, people can tend to try to put too much contextual information in it and explanations as to why failure occurred. Oops, sorry. One last slide. I want to talk about process audits for just a minute. I think this is probably one of the most difficult things to do, because there are a multiplicity of steps in many of the processes that we do in healthcare. And you really need to break down the steps. Our first go-through, we used a template, as Linda can attest, and we found after piloting it that key things were missing. For example, whether the housekeepers introduced themselves when they came in the room, whether they had hand hygiene and task-specific glove use. So we had to go through a few trials, refining the tool till we felt that it truly encompassed all the steps, because until it does that, you can't break down where problems are occurring. So if you're going to develop a tool, see if you can borrow something from somebody else if they've already piloted it, and keep in mind that you're going to have to refine it. And there's a real issue with covert observation. It's difficult to observe covertly. We're going to try different ways, but I think in the end you have to realize that people are going to know that they're being observed, and you just make it as part of the learning process, and it's going to be consistently inconsistent. It's going to be a factor in the whole process audit, and again, what you're looking for is changes over time. It's interesting, this was sort of forced upon us. I was a little worried about what the IPCs would say about taking on this role, and I think it's up for debate whether we continue on in this role with our environmental services folks, whether it's really the function of an IPC or whether it can be given to somebody else to do. But I think they would agree that it was really an invaluable learning process. We had so many good observations. It was done in the spirit of goodwill. And we were able to get themes, time of days, hospitals, groups of surfaces, types of cleaning, and we're just about to embark on the next phase of putting in corrective measures, waiting for time to pass, and then monitor again. So, to wrap up, I think that you should combine both process and outcome measures along with a level 1 program that is some sort of a competency evaluation, and it has to be regular. It's no just off the mark and yeah, we did okay and that's the end of it. You need to observe the trends, and it has to be regularly reported in a consistent manner to senior management. I agree it has to be transparent and public. I don't think we're quite there yet, Mark, and it needs to be acted upon in a collaborative manner. Without that, I think you're not going to get the change management that you think you could. And I'll end it there and entertain questions. Thanks.
Thank you so much, Dr. Bryce. We do have a few minutes for questions if anybody wants to come up to the microphones and ask.
Dr. Bryce, we have traditionally used contact precautions for VRE in a healthcare setting, but I hear there's a move afoot to stop this process. And I just wondered if there's any concern about the cleaning after that happens, or should hospitals decide to go that route? Is there a big concern about that?
Okay. Such an interesting topic, a topic in on of itself. I think people, the grapevine works well, and you know that some of us are considering a risk-managed approach to VRE, and some folks have already done that, where not everyone who has VRE will be automatically isolated and have contact precautions. And yes, there is a concern about cleaning, and I think before you embark upon a risk-managed approach for VRE, you better have the fundamentals in place, not just for surface equipment, surface cleaning, but for mobile equipment cleaning. We put in a business case that was actually just accepted 3 weeks ago, and we called it the 4 cornerstones of infection control. The first was hand hygiene. The second was standardization of methodology, policies, and procedures. The third was antimicrobial stewardship. Jim, you'll be heartened to know, and we actually got people for that because we really didn't have, everything was being done off the side of everybody's desks. And then the fourth was more investment into surface cleaning, but more importantly, defining the roles and responsibilities and dedicating people to clean mobile equipment, because we just don't do it well enough. And we have been asked to do a return on investment to make ourselves self-sustaining in 3 years. And what our counter is that we will not go to a risk-managed approach for VRE until all those other pillars are in place. And furthermore, we won't stop monitoring VRE because we don't feel comfortable about making the switch without measuring the outcome. So we'll continue to monitor for VRE in the lab the way we do. We will then assess what the impact that is over time.
Well, thank you so much.
Well, thank you, folks.